Hey everyone, thank you again for inviting me. It's an honor to share the space with so many incredible speakers, and the space itself is pretty incredible. This is probably the most interesting podium I've ever used. So my name's Manik. I'm the CEO and one of the co-founders at Healthify. And at Healthify, what we're really trying to do is build solutions and the infrastructure necessary to address social determinants. And before I get into the nitty-gritty of what we really do on the ground, I want to talk a little bit about where we came from and how we got started and why we got started. So we got our start working in East Baltimore in a community that has a lot of need. We were working at a pediatric clinic, and I see a fellow volunteer here that I was working with for 3 or 4 years, working at a community psychiatry clinic and actually doing community health outreach for a men and family center for about 4 years. And I think I'm preaching to the choir when I say that what we saw day in and day out was, at the end of the day, a majority of an individual's needs were linked to social needs. Food insecurity, housing, childcare, access to mental health services, GED programs, access to transportation. We saw these issues every single day, but we had no good way to actually address it. And some of the major pain points we identified were, first, screening. You know, understanding if a family is food insecure right now from the healthcare's perspective happens about 12% of the time. So think about that. In a population where food insecurity is very prevalent, we have no understanding of what is the severity of the need in a family, and it's not really stored in any health record system either. Even though we know that if a family is food insecure, they're 40% more likely to be hospitalized and much more likely to have poor health outcomes down the road. So that's one major pain point. We have no good barometer of knowing what are the needs that are actually there. Second major pain point, which was alluded to earlier, is that there are some incredible services and organizations on the ground, in the trenches, doing great work, thousands of them, and of course benefit programs. But figuring out what services are open, what services are actually working well, what the information is to share, was very tough to do. The information is mostly paper-based, not validated, nearly impossible to share with individuals who need help, or impossible to share with staff members who need the information as well. And none of it is tracked. So even if we were lucky enough to know that someone had a need, figuring out the service that could best help them was impossible. And then the final pain point we identified was follow-up. So we had an expanding caseload, and of course with Medicaid expansion, caseloads in the healthcare space keep increasing. And imagine trying to call 60 families, understand their needs, figure out if the referrals are working, if they went, if they need support, along with actually managing the chronic illness they might have, compounding on all these problems. And you get a good picture that this was basically an untenable situation, that follow-up could not happen and really did not happen. And that's really the context of why we got started. We said there's got to be a better way to a lot of this and coordinate around social services. I don't think, as we'll probably get in the Q&A, I don't think there's a perfect solution to a lot of these needs. Where we kind of looked at it that we don't want perfect to be the enemy of good. And if we're serious about healthcare, and I have a slide here, you know, 1/5 of healthcare spending linked to social needs, 60% of health outcomes. If we're really serious about value and improving the health communities, we need to be really methodical about how we understand social determinants and their relation to health. So what do we do? So we do a few things. One of the first things we do, and we share this with other people on the stage, is we get a good understanding of what services are available. And we pull out from a lot of local, state, and government data sets. For example, Department of Veterans Affairs has great data sets on homeless services for veterans, or caregiver support services for veterans and veteran areas to get help generally. Or SAMHSA has great data sets available for looking at what are mental health and behavioral health services in certain communities. We pull all this information, we standardize it, we validate it, and categorize things to make sure they're readable, 4th to 6th grade reading level for descriptions. We make sure that the intake requirements are categorized appropriately. We explain who the service is really for and double-check hours of operation. And that's really the first step. When we put this in an interface, kind of like earlier someone alluded to a Yelp of services, very similar. People can rate, edit, comment, share, and look at these services in a more effective manner and trust that this information is accurate. And then we actually have a screening system that understands needs and matches people to services. And this is primarily built from research coming out of Boston Children's Hospital, where we ask questions about an individual's social needs and then automatically connect them to a service. So if there's a single mother with a child under the age of 5 who has self-identified through the patient-generated data that they might need help with the crib but can't afford it, we will direct them and provide them transit directions to actually find access to a community center that's helping with infant child supplies and automatically determine the eligibility for WIC and the next steps for applying. That saves quite a bit of time. And really the value of this is we then give all this information back, and one can actually see in a population who is most at risk, what are the needs that are actually popping up, what is the service gap between needs and what services are available, and then we go ahead and automate follow-up as well. So we text individuals primarily right now about how things are going, if they need more help, and actually ask them to rate services as well, so we finally get the other side of the equation of what do people who are accessing these services think about them, and are they actually benefiting, and what are their thoughts on it? And I think that's hugely valuable. And we're actually working on what we've always wanted to do, which is full coordination of these needs, where the agency in question is on the same platform, and the referral is sent to them, and they understand what's going on. And we're doing this with a PCORI-funded trial out in Baltimore. And that's really the end goal is, if you have a full coordinated system with patient-generated data, with interventions, with engagement, how does it affect outcomes, and how does it affect claims data down the road? And we're trying to build the systems in place to make that happen. And so where are we right now? So I'm proud to say we made a lot of progress in the past almost 2 years now, a little over 2 years. We're live in 8 states. We have over 1,000 healthcare staff using the platform daily, and these are community health workers out in the field. These are nurses. These are case managers, behavioral health specialists, and we have hundreds of other community-based organizations using the platform as well. We have 3 ongoing research studies with PCORI and AHRQ that are really looking at this holy grail of if we really look at social determinants and coordinate around a referral, what is the impact to make sure it scales in a managed care setting or otherwise? And we have some great people we're working with. Johns Hopkins Healthcare, where we're from as a client, Banner Health, Philips Healthcare. And I can't name any names, but we're also working with one of the largest health insurers in the United States, too. Thanks so much.